Welcome to an interesting topic on how structural racism in America informs fertility disparities for Black couples. I am Sarah Ramaya, Curriculum Design Strategist and Webinar Coordinator at ASRM. Our moderator for today's session is Dr. Gloria Richard-Davis. She is the Executive Director for the UAMS Division for Diversity, Equity, and Inclusion. She is also Tenure Professor in Obstetrics and Gynecology and Board Certified Reproductive Endocrinologist and Infertility Specialist with over 25 years of clinical experience in REI and women health research. She is the chair of the ASRM Diversity, Equity, Inclusion Working Committee. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of this presentation will be allotted for a question and answer time. We will read as many selected questions as possible to the panelists. Please send in your questions through the Q&A window. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Over to Dr. Richard-Davis.
Thank you so much, Sarah, and welcome everyone. We are so excited you've joined us for this critical conversation on how structural racism in America informs fertility practice for Black couples. We have a very distinguished group of panelists tonight with expertise and passion in reproductive medicine, as well as health equity. We were very intentional in the choices of topics and hope you find this helpful and relevant. In the words of MLK, all forms of inequality, injustice in health is the most shocking and the most inhumane, because it often results in physical death. While infertility is not physical death, it has significant impact on the couples that are affected. Black women's voices have been silenced for too long. We must be their voices, and we are here tonight to talk about barriers Black couples face in seeking fertility treatment. So our distinguished panelist includes Dr. Tia Jackson-Bey. She's a reproductive endocrinologist and infertility specialist who cares for patients at RMA of New York in Brooklyn, New York. She's an assistant professor of OBGYN and reproductive sciences at the Icahn School of Medicine at Mount Sinai. Dr. Zachary Walker is a first-year reproductive endocrinologist and infertility fellow at Brigham's and Women's Hospital. He completed his residency training at the University of Alabama in Birmingham. Ms. Mikesha Middlebrook is the clinical office manager for Bloom Fertility and Invo Center in Atlanta, Georgia. She received her undergraduate nursing degree from Emory University in Atlanta, Georgia. Dr. Denise Asafu-Adjei is a urologist and assistant professor at Loyola University Medical Center in Chicago, Illinois, where she serves as the director of male reproductive medicine. She's also an adjunct assistant professor in the Parkinson School of Health Sciences and Public Health. And Dr. Kim Thornton is the director of the Division of Reproductive Endocrinology and Infertility at the Beth Israel Deaconess Medical Center, and assistant professor in the Department of OBGYN and Reproductive Biology at Harvard Medical School. And she practices reproductive endocrinology at Boston IVF. So that is our lineup for tonight.
Thank you so much, Dr. Richard-Davis. These are my disclosures. So with increasing awareness of persistent disparities in obstetrics and gynecology, and particularly factors that contribute to increased Black maternal mortality, I always find it interesting that disparities in infertility care are somewhat overlooked in this conversation. Reproductive disparities are part of a larger reproductive justice issue. It determines who has the ability and the access to have the tools that they need to start their families. And thus, infertility care must be considered in the full spectrum of reproductive health care. At the core, disparities in comprehensive obstetrics and gynecologic care contribute to racial and ethnic disparities in infertility overall. As compared to white women, Black women are half as likely to present for care, have a longer duration of infertility at entry to care, have lower utilization of the most effective treatments, and higher rates of treatment discontinuation, as well as poor treatment outcomes even after care is initiated. However, just knowing that disparities exist feels like the tip of the iceberg. We know there is so much more to unwrap beneath the surface, and therefore, when considering health disparities, barriers to care often extend beyond finances and more into attitudes and beliefs that inform our perceptions of options, choices, and who deserves to build a family. So there are a few basic tenets of infertility that I think are important to observe. One, infertility is a disease of the reproductive organs. This is not a social problem. It's not a rich person's problem. It's not a punishment for past transgressions, be it social, personal, or religious. And it's very often no one's fault. Infertility does not discriminate. Despite cultural, historical stereotypes that we'll discuss tonight, either externally imposed or internally perpetuated, anyone can be affected by infertility. Lastly, infertility is not a dead end. For so many, the diagnosis is really only the beginning. Fortunately, we are living in a time of unparalleled options for fertility treatment, but in order to treat, you must recognize that there is an issue. There has to be interactions with the medical community for diagnostic testing and treatment. So before the goals of care are reached, there can be so many different points for dropout. And often the hardest part is identifying that there's a problem at all. Another important thing to remember is race is a social construct. It's a convenient method of categorizing humans that at one point was to place value on humans based on how they looked or perceived common ancestry. I actually like this definition of race from Merriam-Webster, which is any one of the groups that humans are often divided into based on physical traits regarded as common among people of shared ancestry. I like it because it serves as a reminder that physical traits do not equal biologic or genetic differences. So this is just something to remember as you're interpreting disparities data. Yet in 2022, we remain confronted with prevailing idea that Black women don't have infertility. I think personally, everyone involved in this panel has either heard this, sometimes in our own families or social circles, amongst colleagues, or even from the patients who are sitting right in front of us. As a clinician and a researcher, we know that this is not true. However, this stereotype of the hyperfertility of Black women is difficult to dispel at both the individual and societal level. But I can't help to wonder, where did this stereotype begin? Well, I know this part can be very difficult to discuss, but the origins of this myth are with slavery. Slavery isn't a part of American history, and it is so integral to the Black fertility myth. In order to understand where we are today, we have to take an honest and even sometimes a new understanding of the past. So for Black people in America, there is no examination of the past that does not acknowledge the institution and the legacy of slavery. It is also important to remember that the slave trade was more than just slavery in America. This was a global transaction that fueled the economies. The triangular trade was named due to the flow of humans, goods, and services across the Atlantic. So humans were brought from Africa into the Americas to work. The production of their labor, cotton, tobacco, sugar, timber, was then exported to Europe. And then from there, weapons, textile, and alcohol was used in Europe, often as currency to secure more humans. However, as slavery began to flourish as an important method of economic growth in the late 17 and early 1800s, the founding fathers of the United States, despite both tolerating and participating in the enslavement of humans, actually enacted a series of laws to limit slavery. The most important of these took effect in 1808, which limited the importation of slaves from Africa. But this also placed persons who sought to increase their wealth through slave labor with a real quandary. They had a diminishing supply at a time when they really needed and had an increase in demand. So the solution was to create new humans for the purpose of enslaving them. These homegrown slaves were born on US soil, but not considered citizens. So there was a practice of creating new slaves, and it was exactly as crude as it sounds: breeding. Whether slaves were forced to have sex with one another or with their white enslavers, the same was true. Now the value of a human became linked with how many offspring they could produce that could also be enslaved. And those would be even more, those who could have more children were thought to be more financially valuable. So the reproductive capacity of both Black men and women became synonymous with their worth. And this demand for more enslaved humans fueled the world's economy, but also added to the brutal realities of this peculiar institution. Now, the reproductive capabilities of Black women were so valued that much of what we know about modern gynecology is actually owed to the bodies of enslaved Black women. James Marion Sims earned his professional reputation as the father of gynecology through his work on enslaved women who were either leased to him for medical care or who he outright purchased, as he spent years working to understand and surgically repair obstetric fistula. This required multiple examinations and surgeries without informed consent or anesthesia at that time. His experimental subjects, who were and actually his de facto surgical assistants as well, Lucy, Betsy, and Anarcha, are currently being reclaimed as the mothers of gynecology, given their contribution of their bodies against their will to reproductive medicine. This legacy manifests in the mistrust of the healthcare system, particularly as it relates to reproductive health. Thus, the Black fertility myth both directly and indirectly affects the reproductive health and care of Black women to this day. This mythical, magical idea of fertility abundance, without really acknowledging the circumstances that led to the prized reproductive capacity, is destructive to the process needed to overcome reproductive disparities. So as physicians and providers at all levels, we ought to make ourselves aware of the inherent biases we have and understand that our ideas of Black fertility can actually serve as a barrier to care. Further, these ideas are often held by Black people themselves without even noticing it or consciously being aware of it. And it limits their recognition of fertility challenges, and that also serves as a barrier to care. So today, I continue to see the impact of these experiences from years of slavery and the next century thereafter. On an individual and community level, I see how family history of large families or later conception can sometimes mislead persons into thinking that their fertility may not decrease with age, that they can have significant grief from an infertility diagnosis, particularly if this is not something you were ever aware could happen to you. There may be a lack of social support, especially if they don't see other women who are going through this process or know of other people in their social circles who have had these same circumstances, as well as a lack of reproductive awareness in terms of what's normal and not normal and when to seek care, as well as a mistrust of the medical system. In terms of larger systems and provider issues, this translates into absent and late subspecialty referrals for infertility care, as well as a singular focus sometimes in their interactions with providers on contraception without considering the broader family planning goals. There can also be assumptions on reproductive timelines, especially when detailing cancer or uterine fibroid treatment that may not be properly explained to patients, as well as bias about the ability to afford care or perceived patient compliance and who is worthy of fertility treatment.
Thank you so much, Dr. Jackson-Bey. That was phenomenal. Our next speaker is Dr. Zachary Walker. Zach's response to his why is he interested in this area? He says, being an African-American male, gay male, in an OBGYN field, I have always felt like a minority. Researching racial disparities is my way of trying to level the playing field for my patients and advocating for those who don't have a predominant voice in healthcare. So with that, Dr. Walker.
Thank you so much, Dr. Richard Davis. I want to thank you and the ASRM for inviting me to be a panelist for this very important topic. As you stated, racial disparities are very important to me and something I will continue to research and advocate for. I've done some prior research in the area, and I want to continue developing more research moving forward as I finish my fellowship and becoming a future attending. And I hope that the people who are attending this conference gain some insight and hope some new knowledge about this topic. So let me just go ahead and get started. So I have no disclosures. First, I wanted to highlight the ASRM Ethics Committee opinion that was released in 2021 pertaining to disparities in infertility treatment. I have captioned some primary quotes from their statements here that I just want to review. So the first one being, building a family is a basic human right. Everyone should have equal access for family building, not just the wealthy, as Dr. Tia Jackson-Bey was stating earlier. The second quote, I kind of paraphrase, highlights that systemic discrimination is recognized by ASRM and plays a role in disadvantaging certain minority groups. Next, ASRM highlights it is a responsibility of everyone providing reproductive care to be proactive in lessening the barriers to access to care, not just physicians or minorities in the field of REI. It's the field of everybody who provides care to reproductive age women. Lastly, educating underserved populations is a primary focus, and we need to do more, which brings me to the main topic of my discussion of fertility awareness. So the first study I wanted to highlight was this study done by Siegel et al., published in August of 2021, entitled Racial and Ethnic Disparities in Fertility Awareness Among Reproductive Age Women. So the objective of this study was to investigate the impact of race and ethnicity on fertility awareness. They used a cross-sectional survey using a standardized survey called the Fertility and Infertility Treatment Knowledge Score, or FITKS for short. They dispersed this survey using an Amazon platform and had about 405 responses. Their main primary findings were that the minority group scored lower than the white group in terms of their knowledge about infertility treatment. Also, they found that the minority group were more likely to underestimate the rates of miscarriage and risk factors associated with infertility, including smoking, obesity, and/or history of gonorrhea, chlamydia. We know that most minority children attend public schools and that most of these schools are underfunded. So this lack of knowledge may stem from early childhood about not having the education or being aware of what to look for or what infertility is. So these schools that are underfunded or understaffed do not have appropriate resources for effective teaching, and this may cause a disadvantage to start from early childhood. This disadvantage at an early age impacts adult learning and contributes to the lack of awareness in regards to infertility. It is up to providers to educate their patients on these topics and dispel any myths that their patients may have, such as what Dr. Tia Jackson-Bey was saying earlier about the Black infertility myth. The next topic study I want to highlight is one done by Sonia et al. It was published in 2020. So the objective of this study was to test the hypothesis that underrepresented minority women will be more likely to report greater socioeconomic and cultural barriers to infertility care compared to white women. They also wanted to identify gaps in knowledge that can guide future educational interventions. So this study was close to home. This was done in Boston. It was conducted, which is in Massachusetts, which is a mandated state for insurance coverage of IVF. They had about 242 responses, and their main findings revealed that cost was the most commonly reported barrier to care, except when they compared those with a history of infertility. They also found that most women were unaware of their insurance coverage. This shows that being in a state with mandated coverage does not eliminate barriers to access, and we need to provide more attention to fertility awareness to allow patients who are in these mandated states to know exactly what their insurance does and does not cover in regards to infertility. There are other states within the US that do provide IVF coverage for infertility. However, there are some differences in what that cost is and what they may or may not cover. So it is up to providers and other clinicians to know exactly what may be included and how best to guide patients when they're going through their infertility journey. Lastly, there was an interesting study that I found done investigating African-American women's awareness of the possible impact of cancer treatment on infertility. So this study was conducted in Florida, and they distributed a cross-sectional survey that asked two critical questions. One, were you aware that some treatments you may have received for breast cancer may lead to loss of your future ability to have children? And two, did your doctor ever discuss the possibility that treatment for breast cancer may lead to a loss of your future ability to have children? So approximately 50% were not aware of the potential impact of cancer treatment on their infertility. And then also approximately 40% of women reported that their physician did not speak with them about fertility. This is a large group of patients who are coming through getting this care and not knowing about the risk undergoing this treatment. So that this shows that African-American women are receiving a disservice in regards to their reproductive health, and maybe primarily due to the lack of education or awareness in this area. So they may not know to ask. This further perpetuates the mistrust in the African-American community and with healthcare that Dr. Tia Jackson-Bey also highlighted in her discussion. So to summarize some of the key points I just want some people to take home is that further studies are needed to explore fertility awareness in the African-American community, given that 2 or 3 of these prior studies included more than just African-American women when they summarized as minorities. And when you look back at most studies that look at racial disparities, African-American women are not they don't have a high percentage of the respondents. Usually it's around 10 to 20% or even as low as 2 to 3%. So we need more data focusing on this community to see exactly what is going on. We need to be vigilant with educating and informing patients of their fertility health in relation to their overall clinical health, in accordance with ASRM overarching goal in regards to racial disparities and infertility that was previously stated in the Ethics Committee statement. We need to continue to advocate for a mandated infertility coverage because every little bit helps when we know that IVF is very costly, and any way that we can reduce that cost or eliminate that cost will allow more people to receive the care that they need. And then lastly, developing learning opportunities to educate healthcare providers of reproductive age women on how to discuss fertility concerns, offer treatment, or assist with referrals to an infertility specialist is something that we need to continue to strive for to make sure that everyone is aware to bring this up in discussion and also know how to get patients to where they need to go in the correct amount of time and not to delay, because it is known that most African-American women or people of color kind of seek this care out when they're older or may not know that they need to seek care sooner.
so much, Dr. Walker. Before our next speaker, I want to queue up one more audience response question. Do we have that, Sarah? So if you are a reproductive endocrinologist provider, how many IVF cycles are annually performed at your primary practice? If you're not the provider, if you can answer for your center or practice, how many cycles are done? I feel like we should have music with this. Do, 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 do. And the answer is, wow, some pretty big centers on. Okay, thank you guys so much. So our next speaker is Ms. Mikesha Middlebrook, and her response to the question of what drives her in this area. She says, as a nurse, I'm an advocate for my patients, and over the years, I've heard minorities express issues with this subject, which is why I wanted to speak on this topic. So she's going to enlighten us on the patient experience in the infertility space. Thank you, Mikesha.
Thank you. And I am so excited and honored to be here and to be able to discuss the topics that we have today. Being a clinical manager and being an infertility patient myself, I really feel that the patient experience in the infertility space is something that's very important. And all clinics really need to look at how we are handling our minority patients as well as our African American patients and making them feel as they're welcome in the office. I do not have any disclosures at this time. So I think that there are three main topics that we need to look at to make sure that we are meeting the needs of our patients. One is the journey. Infertility is a journey. Who will the patient meet along the way? Conferring with physicians, providers, and fertility medical staff who are also African American is an important component to the patient experience. Why is that? The patients feel they know me, they understand me, they can give me authentic and firsthand advice. They don't buy into the myths about African American women being fertile. They can empathize with me, laugh with me, and encourage me as a peer, someone relatable, and they can trust their team. Another area I think that we need to spend a lot of attention on and do better at is our marketing and advertising. Marketing demographics should include all communities where those who are trying to get pregnant may be reached, educated, and informed about services and treatments available. African American patients evaluate, am I represented in print, digital, billboard ads, and collateral? In the interior office decor and art? Am I included in the conversation as it relates to focus groups and surveys? Is my opinion considered and valued enough to affect change? And then another area is, of course, education and support. Diversity and inclusion must be a part of the everyday experience. The conversation, the onboarding process, the standard operating procedures within the practice should reflect openness. Most importantly, are African American patients being heard, being supported, being cared for equally? Offices without African American providers or staff, do they cultivate an environment of acceptance, learning, and genuine care for all? And do they have cultural sensitivity training for all? This is something that I think we need to take back to our clinics and start to have conversations. We need to look at how we are representing ourselves and also representing our groups of patients that come into our office. One of my favorite quotes by Dr. Maya Angelou, she sums it up the best. People will never forget people will always forget what you've said. People will always forget what you do, but people will never forget how you made them feel. Thank you for your time.
Thank you so much, Mikesha. It was wonderful. So our next speaker, we have one more poll question before we get to our next speaker. So Kim is urologist, and Denise's answer to her why is she's passionate about improving access to care for male factor infertility and exploring innovative approaches to patient education and outreach through social media and other settings. Dr. Asafu.
Hello, and it is such a pleasure to be amongst my REI colleagues. I think it's so great, and I really, thank ASRM for continuing to have us in the conversation. I think as we continue to think about barriers, we have to continue to remember that there are two sides of the coin. And so I'm really happy to talk with you today about some barriers to male infertility care and hopefully encourage us to continue to work together in the fight for fertility for us to think about how our patients can be best served. These are my disclosures. Now, most of you correctly answered this poll question, but so infertility, as we know, affects about 15% of couples worldwide. Male factor infertility exclusively accounts for about 20 to 30% of infertility cases, but contributes about 50% of infertility cases overall. In North America, male infertility affects about 4.5 to 6% of men, with global rates of male infertility ranging from 2.5 to 12%. Now, keep in mind, I'm not going to show those maps today, but keep in mind that a lot of these surveys, when we think about epidemiology, requires people to participate in these surveys. Men in general seek out healthcare listed women. Similarly, polls related to, sexuality and infertility also tend to be a little skewed. So these numbers are a little bit more accurate when we think about the Western world, but there is a really wide range of numbers and figures that we find when we kind of get out of those spaces. So just keep in mind that, these are numbers, but we don't really truly know how many men are coming forward and talking about their infertility. I want to talk today about several barriers to male infertility care. And I think especially for most of us here who are, largely dealing with women, I think it's really important for us to think about, for those that have male partners, how they are being affected and how we should also continue to be champions for them. Limited urological workforce. I am one of very few women in the world of male infertility. We have an annual census in our American Urological Association. Urologists overall are quite underserved to the US population. There's on average about 4 urologists for every 100,000 people. So if you think about that, where are men, where can they even go to really seek this kind of care? And when we parse that down even more to availability of male infertility specialists, per our most recent census, about 3.4% of urologists pursue fellowships in male infertility. Overall, about 50% of residents are pursuing fellowship training. So we remain a very, very small minority of urologists who are specially trained in treating this. So this is, just an area that we need to continue to be vigilant about and something that we are actively, trying to change the tide with. Male infertility awareness and education. There continues to be a global lack of education and awareness that men can suffer from infertility, driving the overall low rates of men seeking medical care for this. Stigmas about male infertility and implications on masculinity continue to permeate many communities, still deeming infertility as a woman's problem. So early education and awareness about fertility really lags in men compared to women. With insurance inequities, which we briefly mentioned before, despite infertility really being a disease, it's well established that infertility care is expensive and it's not a covered benefit in most insurance plans. There was a great study by my colleague Dupree et al. Out of University of Michigan in 2018 that focused on insurance coverage of male infertility. And what was interesting is that he really highlighted several gender disparities in insurance coverage, comparing men and women, with only half of the states with mandated coverage for infertility even mentioning male infertility. So this, continues to be really a major area from a policy, law standpoint, just to create parity in infertility care between men and women. When we exclude men from the fertility conversation, it makes them less likely to seek evaluations, and it places undue burden on their female partners. Insurance coverage would also expand our ability to research on many more undiagnosed male infertility risk factors, genetic factors, and intervention opportunities in male infertility. So really is a major issue that we also have to continue to think about in regards to barriers. In regards to donor sperm utilization, in the United States, we do not track the use of donor insemination. So private sperm banks are not required to release the ethnic groups of their donors publicly. This is really important. Our conversation today is focusing on Black couples. Black couples that have the means to pursue fertility care. Some of them want children that may look like them. And so for those males that may require donor sperm, it's actually a major problem when they're thinking about, where do I go if I want to find a donor so that my child may look like me? And then finally, religious considerations. So religion is a major driver of attitudes regarding infertility treatments. It can really influence attitudes towards subsequent medical care. There are varying degrees of support and allowances for male infertility treatments in Catholicism, Islam, and Judaism. I work out of a Catholic institution here at Loyola, so I'm acutely aware of some of those barriers, both on the male and female side in regards to fertility care. And religion can also dictate support for married and unmarried couples and those who identify in the LGBTQ communities. And so these are all just kind of the major points I really want all of us to think about when we are engaging couples. Do not leave men out of the conversation. And there are unique barriers that we find in male fertility that are important to think about. I also wanted to get more specifically on medical mistrust within the African-American community. There really is widespread attitudes that stem from many unethical yet sanctioned medical experiments performed on African-Americans. For hopefully anyone who's taken any kind of training to do clinical or any kind of research has hopefully read about the now infamous Tuskegee syphilis study, which is perhaps the most widely known study exclusive to African-American males. For those of you who do not know, it was conducted in the United States by the United States Public Health Service from 1932 to 1972, in which researchers withheld treatment from about 400 Black men in Mason County, Alabama, in order to study how syphilis worked and how that progressed. And the study continued, had men in these studies without treatment, and even when treatment was available, many of these men were still denied the standard of care. Now, this study has become to many really a classic and historical case of blatant governmental racism against African Americans. And it's one of the major reasons why many African Americans distrust the healthcare system. And I bring that example to say, when we think about syphilis, its context as an STI and just sexual and reproductive health, it really has played a significant role in how Black men are coming forward to even talk about or have conversations around male infertility. I'm with my REI colleagues today, so most of you hopefully also know about Henrietta Lacks and the HeLa cells that have really contributed to many medical breakthroughs in various areas of medicine. But when we think about, again, this is a woman who came in for treatment for her cervical cancer, and without consent, her cells were used, and it did a lot of good in this world, but still had really long-lasting impacts when we think about consent. Again, something that's related to really our sexual and reproductive health. And then finally, sterilization programs. Sterilization programs were pretty common in the United States up until the 1990s, if you can believe it or not. They took place across 32 states, resulting in more than 20,000 men and women being sterilized without their consent. And, these sterilization programs targeted Blacks and other minority groups, the mentally ill, immigrants, the poor, unmarried, those who are disabled, and it included participation from physicians. Now, the 1990s wasn't that long ago. In December 2015, the US Senate actually passed the Eugenics Compensation Act to help survivors of forced sterilization. So these are all things that, again, happened within a lot of our lifetimes, not that long ago, but these remain pervasive in our thoughts when we think about, what people think of the healthcare system, particularly around their reproductive health. Now, there continues to be major mistrust and fear of the healthcare system by African Americans, which has really, unfortunately, resurfaced during, this pandemic. And so, although bioethical research has really advanced, intervention for fertility can still be seen as experimental, with a lot of skepticism about its ultimate use. So, these factors worsen the structural barriers we already face when addressing male factor infertility. Thank you.
That was wonderful, Denise. Thanks so much for that powerful, informative presentation. So we'll move on to our last speaker, Dr. Kim Thornton. And Kim's response to her why, her passion. She's passionate about increasing awareness of infertility and access for patients impacted by infertility, and in working to develop strategies to diversify the workforce in the field of REI. So Kim will talk to us about why culturally informed care matters. Dr. Thornton.
Thank you. So thank you, Dr. Richard Davis and the ASRM for the invitation to speak this evening. I'm going to address the topic of why cultural informed care matters. My disclosures on this slide. It has been well established, and Dr. Bey highlighted this very well, that even after you adjust for multiple variables, there are significant disparities in the quality of healthcare that's received among many racial and ethnic minority groups. Black women are half as likely to present for fertility treatment. They often have a longer duration of infertility. They tend to have a lower utilization of effective fertility treatments. And even in mandated states are more likely to self-pay for services than non-Black women. Black women have lower clinical pregnancy rates and live birth rates compared to white women in both fresh and frozen ART cycles after you've controlled for BMI and infertility diagnosis. And in states where there are insurance mandates, there's been a demonstration that they oftentimes will discontinue treatment earlier. So this discussion, I want to discuss some of the factors that we need to consider as we work to correct many of the disparities among access. It's well known that each of us are a product of the culture, which is the learned and shared knowledge that specific groups use to generate their behavior and interpret their experiences in the world. And it's also where we acquire the values that inform how we think and interact with others. So this, as providers and as well our patients bring to every patient encounter their own set of values to this encounter. In addition, we all may bring implicit or unconscious biases, and those are the attitudes and or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These biases are oftentimes favorable, but can also be unfavorable, are activated involuntarily, and oftentimes without our awareness or intentional control. And so it's incumbent upon us to understand that there are unconscious biases that we all bring to encounters, and then recognize how they might impact the care that we deliver. So in terms of what are some of the provider biases, as we've discussed, Black women oftentimes receive later referrals for infertility. So you might ask the question, why is this the case? Well, if you are a provider that believes that a patient may not comply with the rigorous treatment schedules required of fertility treatment, or if you think that the patients may not be able to afford the care, then you may make the decision not to even refer them for fertility care. Therefore, you've deprived them of the opportunity to, one, inform themselves about their infertility and the treatment options are available, and let them make the decision about how they would choose to pursue fertility treatment. Additionally, we all make assumptions around whether we think people either need more children or deserve to be parents. Oftentimes in our counseling of patients, and especially when you think about primary care providers and generalists practicing gynecology, we often have a narrow focus when we're counseling patients on contraception rather than reproductive life planning and family building. So in fact, ACOG has recommended that reproductive life planning be included as part of the of a woman's annual exam so that we can make sure that we start the conversation with patients. And finally, there is oftentimes a failure to address the various diseases that are common in Black women, such as PCOS, or the presence of uterine fibroids, or blocked fallopian tubes, or obesity, all factors that may impact future fertility. And if they're not addressed early, our patients may actually present and then have conditions that are really devastating to their likelihood of being able to conceive. Patients also come with biases, and these have been addressed earlier, but in many instances, the concept of hyperfertility and or family history of large families and late conceptions in parents may give women the false sense of security regarding their own ability to have children. And so that may factor into why they present later for care. They may oftentimes feel shame and feel less or inadequate as a woman because of the infertility diagnosis. And then it is been well described that there is lack of support within the community. And this community can be family, it can be friends, it can be the church, which is oftentimes a institution that provides African Americans in particular a lot of emotional support. Around in the area of fertility, individuals find that they're often going through this journey alone. Religious belief systems are oftentimes complex. And when you look at many religions that are very fundamental, sometimes comments that may not be intentional, that either God will cure an illness or it's God's will that you have infertility, will cause patients to pause and as a consequence, delay their care. And then we've talked about the fact that there's a lot of lack of knowledge about female reproduction in general, the factors that impact outcome, fertility preservation, and the like. The distrust of the healthcare providers has been mentioned mainly because of historical factors. And so I think if we as providers come into an encounter recognizing patients may have some of these biases, we can address them head on and maybe impact the type of care and the comfort they feel in the consultation. So what are the things that we can do to provide a culturally informed care? One is use a patient-centered communication style that will allow us to develop mutual understanding. Part of that includes asking open-ended questions about the patient's life circumstances, and get into discussions in many instances about the values that they have and the preferences that they may have with regards to their fertility care and fertility journey. Avoid generalizing assumptions, which oftentimes reflect the biases we have when you're taking the patient's history and interacting with patients. And then probably most importantly is listen to the patient, listen to the things that she or he tells you, and then respect their cultural beliefs, even if they may be different from your own. In terms of developing treatment plans, it's really important to use shared decision-making when you develop this treatment plan. For some couples, a conservative approach, even trying treatments that you as a provider may not think are going to work very well, may be important to start the fertility journey so that they can then move through the journey at their own pace. And then recognize those factors that may be barriers to care and strategize on how you might overcome these barriers. I had an encounter this week with a patient who is losing her job and is going to have to go on state insurance. But what she didn't realize is that she now has the option to purchase insurance. And without counseling available to share those options, patients don't know. And then finally, understand what your own personal limitations are when you're addressing medical issues across cultures, so that if in fact you need to help patients by either having, financial coordinators in your office or psychologists address some of these issues, know when to engage them as well. One of the other aspects of providing patient-informed care, however, is diversification of the workforce. And when you look at the data, it is clear that when there are healthcare providers of color serving patients with the same cultural background, that these patients have better healthcare experiences and outcomes. When you look at some of the statistics from ACOG in 2017, only 11% of OBGYNs were African American. ASRM, we were able to look at the percentage of members of the ASRM that reported race and or ethnicity. And since it self-reported, only 131 members out of 8,000 members actually reported race and ethnicity. Our hope is that in the future, by requiring reporting as part of the registration, this statistic will improve and allow us to understand the demographic composition of our membership. From the standpoint of resident and fellowship training, the ACGME published statistics looking at how many OBGYN residents and how many REI fellows were African American. 8% of OBGYN residents, or 457 out of 5,677 OBGYN residents, were African American during this year, or 2019 to 2020, and 11 out of 167, or 6.5% of our REI fellows were African American. In addition, there's lack of diversity permeating our nursing community, our laboratory community, so they're embryologists, andrologists, and mental health providers. The focus in terms of increasing diversity in the workforce is therefore going to need to be intentional in order to change some of these statistics. And as part of the efforts of the Diversity and Equity and Inclusion Committee, it was suggested that pipeline programs be developed. These are mentorship or sponsorship or coaching programs to work with underrepresented minorities in medicine to try to increase the numbers of trainees that are recruited into our specialty, number one. And then moreover, looking even further back, trying to increase the knowledge of our subspecialty to individuals pursuing STEM careers to try to change these statistics. I'm going to close with just some general comments. If we can increase the overall representation of African Americans in the REI workforce, hopefully we will be able to elevate the conversation around issues that disproportionately affect African American patients and raise awareness among all providers within the practices. So this goes to this cross-cultural competency, if you will. There have been comments earlier about how the environment within which our patients are seeking care is really important, and making the practice environment more inclusive and reflective of all women and or patients that we see, especially women of color, is important. It will encourage trust among the patients who are seeking fertility care, and also acknowledge the fact that the practices are working well to actively embrace cultural diversity. Additionally, a diverse workforce will encourage healthcare disparity-related research, that will provide us with more information about outcomes in patients of color and ultimately serve as a catalyst for positive change within our specialty. So thank you.
Thank you all so much for those wonderful, wonderful presentation. A lot of valuable, tremendous information, useful information. I want to, before we move directly into the Q&A session, I appreciate those of you who are still on. We will stay another probably 5 minutes or so. So we've got a couple of questions, and I'm going to ask our panelists to be brief in their answers so that we can get through several of them. But before then, one last poll question. Can you cue that up, Sarah? What has your practice done to remove barriers to care for women of color? Have you hired a diverse team, offered financing for patients, create marketing products that are diverse and inclusive, create an office environment that reflects diverse population? Check all that applies. And after Kim's presentation, hopefully. Excellent, excellent. Okay, so we're going to start with our Q&A session. I've got a couple of questions. Dr. Jackson-Bey, when we talk about systemic racism, and one of the terminology that comes up frequently is weathering, and we talk about allostatic load and what impact that has on communities of color. Can you speak to how this impacts infertility in Black women?
Absolutely. Sarah, you can open my video if you want. But yet this idea of weathering is a concept that, with each successive generation, the impact of racism, discrimination, and all the stressors that brings actually impacts health in a very real way. And so this has been studied extensively in reproductive medicine, but particularly in obstetrics, looking at maternity, or how should I say, morbidity and mortality of women in pregnancy, and also the outcomes of their children, and how this is changed over generations, and comparing that sometimes to persons who are recently immigrated to the United States, who tend to have a little bit more isolation from the impact of systemic racism, and notice that their outcomes are completely different. And so this goes to show that if we're assuming race causes these issues, well, we can take people who've come to this country at very different times, that their ancestors have had very different experiences, and shows that actually it's the experience of being here in this country that changes their health course. And so there's no reason for us to think that this could not be something that's also applicable to infertility for all of the reasons that we mentioned today. And so that's another reason that we really need to open our eyes to the impact of biases and how they prevent the advancement of fertility care in this country, but also just to recognize that there's so much more that we have to do in order to overcome this.
Thank you so much for that. We have a number of great comments in our Q&A that I hope you guys have the opportunity to read. But I do want to ask Dr. Asafu-Adjei, given the legacy of exploitation and experimentation of Black bodies, what ways do you think would be the most meaningful way to get reproductive health messages through to more Black men?
So I think, just having honest conversations, I think as we're finding in this new world where people are just acknowledging the biases, acknowledging the facts, I think patients really appreciate that. So I think if you're encountering a couple where, an African-American couple where the male may be more hesitant or, about seeking out care, I think it's okay to acknowledge the history that we have, just saying, hey, like, I know there's been a lot of issues pertaining to, reproductive medicine and health, in regards to like Black men, I do think that things are different now. And I still think it's worthwhile for us to, explore and, just kind of see where you're at. I think when people just know that you acknowledge that that's there, it really makes a difference, as opposed to glossing it over and not, just acknowledging that these are real fears that men are coming to the table with. So that's a practice that I employ commonly, even when I have my patients, and I just say, hey, I get it, but I'm here to help you. And, hopefully this is a new day, and hopefully, you can entrust your care with me.
Thank you for that. Mikesha, many providers believe catering to one group of patients feels discriminatory. How do you feel about focusing on Black couples and individuals for fertility treatment? Should that be done?
Yes, I do think it should be done. I think that it is important for us to recognize that the people of all races have infertility issues. Marketing in TV and advertisement is now starting to broaden, and you see people who look like you. And when you're looking for help, and especially with just the common things we've already kind of discussed of not being able to talk to your family members, not being able to talk to, your coworkers, being able to come into a clinic and see that you're represented, that see that you're welcomed, to see that there are other people who are on the care team that look like you are going to help ease that fear. So I do think we should market. I do think that we should put advertisements into the areas in Atlanta that aren't being touched at all. Because a lot of times you have women who might not even realize that's a question they need to ask themselves and to get help for. So if you're not putting the information out there, sometimes the question is never even brought up. So I think it's not necessarily discriminatory. I think it's just broadening our reach and making sure that we're getting care to the people who need care, no matter what color, what race, what gender. Everyone needs and wants help. We should be able to give it to them.
So just raising level of awareness and leaving no one out. So just being inclusive, really. Zachary, question for you. It sounds like fertility awareness should be introduced earlier, obviously, from your presentation. That's what you said, right?
Yes.
When would you introduce it, and what novel tools would you incorporate to do so?
So that's a very good question. So I think the introduction in school systems will be pretty tough because we're already having the battle of how we educate our children about sexual education and health. That's already across all school boards about should this be included or not. And in some states, that's just like a no. So I think the kind of baton is passed to clinicians when people are coming to their healthcare for you to ask the question, has anyone talked to you about this? Because that's where you get most of your medical education, even from a pediatrician to your OBGYN to your family practitioner. If you're asking questions about contraception, you should also be asking questions about fertility. It's kind of like I recently went through residency training, and it was really instilled in us to like ask questions about contraception, but not really to ask questions about fertility preservation, fertility awareness. So I think even from a training as a resident fellows that we need to bring that as a pivotal question in our normal H&P for new patients and follow-up patients, because contraception is one thing, but also fertility is another. And I think if patients knew that earlier on or knew what infertility was or what to look out for, then we'll have higher referral rates, higher follow-ups, and maybe a higher diagnosis and treatment. So I think that's probably the best way to implement that. And we can start at kind of different levels of training and then target different subspecialties and specialties about bringing up the question at the visit.
Okay, thanks for that. We're going to let Dr. Thornton bring up the rear, close us out with this question. A common response from practice leaders and residency fellowship directors is that they select based on the best qualified candidates. We all hear that, right? Not based on color. What do you think of this comment, and how may this impact efforts to diversify the REI workforce?
Well, I think that institutions now are becoming a little bit more intentional about recognizing that the workforce needs to be diversified, and that the approach to interviewing or selecting residents and or fellows has to change so that you can incorporate other attributes of candidates that, are important in terms of, creating, your physician workforce. And that includes life experiences, various attributes that this individual may have had, competencies, as well as, kind of their academic and or scholarly activity. And so when you do that, you open up the, you're more intentional about looking at your applicant pool and interviewing candidates that bring other things to the table. Most of the candidates, quite honestly, that we interview, for instance, for fellowship, they're all qualified. So then you're looking, for other attributes that may match, kind of the goals of your institution and et cetera. So it's more of a holistic approach than just focusing on board scores or, how many papers someone has written. We also have to acknowledge that not everybody has had the same experiences growing up. And so, the playing field is not always even. And that doesn't necessarily mean that, the end product, whether it be a resident or a fellow, that's our job, to mold and develop individuals into the competent positions that we want them to be.
Absolutely. There was an article talking about the F word, fit, right? That oftentimes we use it to exclude people. And we really have got to acknowledge our biases. One last burning question, which is actually for you. What would you say to an African-American OBGYN resident who is interested in REI, but is afraid of not successfully matching into fellowship?
Who are you asking the question to?
You, Kim.
Oh, me. Well, first of all, I think that, identify a mentor early. If you don't have reproductive endocrinologists at your institution, there are reproductive endocrinologists throughout the country with whom you can contact and potentially work with. Whether that's doing an outside rotation or trying to do research, at another institution, but, be creative about how you try to build your resume so that you are competitive. And, that's the key. And so people, can meet you outside of your own institution. I know of a number of residents who have done just that and are very successful reproductive endocrinologists now practicing in the community. And so it definitely works.
I want to thank all of you for these fabulous presentation and discussion. And I want to thank our audience for participating. We have thoroughly enjoyed presenting this information to you and engaging you. And we will see you at ASRM and around.
Good night.
Good night.
Thank you, everyone.
Thank you.
Thank you to our panelists, Dr. Gloria Richard-Davis. Thank you so much for spearheading such a fantastic and important topic. To our attendees, thank you so much for joining us. You will receive a survey right after this session and by email. Your feedback helps us give you the most relevant information and content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notifications about future webinars. And for any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar. Good night.
Thank you, Sarah.
Good night.
Thanks, Sarah.
Thank you, Sarah.